Hello and welcome to this Vulval Pain Society social media live. I'm Sheren Gaulbert, Vulval Pain Society trustee, therapist and pain science educator. If you can say hi in the comments, then I'll know you're able to see me and you are watching live. And of course you can say hi whether you're watching the replay or watching live. Any questions that you might have as we are live today, please just pop in the comments. We've had a few sent to us in the lead up to this, which I will be putting to our guest. I can see the room filling up, which is fantastic. So our lovely Vulval Pain Society Operations Director, Kay Thomas, is also in the background on Facebook. She has been raving about today's guest for some time, so we're really glad that he's able to join us today. Our guest today, Mr. Peter Greenhouse, welcome. Thank you for being here with us.
Nice to be here.
It's lovely. And you're in your garden, which is even better.
Yeah.
With a glass of wine.
Here in what was sunny France just a couple of moments ago, but it's now a bit overcast.
The topic today is estrogen, Vestibulodynia, and the safety of HRT. Now, before we actually get started, let's hear a little bit more about you, Peter. When you sent me over your biog, it just went on and on. So I've picked out a few bits. Consultant in sexual health and menopause specialist, former sexual health head of service, Bristol, Weston NHS Trust, vice president, International Society for Infectious Diseases in Obstetrics and Gynaecology. Wow, tell us more about how you got into this field.
Well, I think your viewers might well appreciate how I got into the field of sexual health and sexually transmitted infections, because if you think about it, nothing focuses your mind more than having a medical condition. And I'm sure that that anybody who's faced with, for instance, vestibulodynia or vulval pain of any description will be intimately interested in all the latest information and trying to get it sorted out. So as a young lad in my gap year, just like most people did, I managed to catch a sexually transmitted infection. I got chlamydia. Cheers. Pretty well everybody has got chlamydia. And in fact, if you haven't had chlamydia by the time you're 30, what have you been doing with your life? You could say, you just haven't been trying hard enough. Anyway, cut a long story short, I eventually got to a clinic in Amsterdam. I got myself brilliantly treated. I was actually totally, well, shit scared is probably the best description. And I was brilliantly looked after, and they were just so welcoming and so non-judgmental and so kind. And then when very much the same sort of thing happened to me as a student at Cambridge, I got the same reaction, and I thought this is a sort of branch of medicine that I could do, because it's a very friendly field, and it also has a certain immediacy to you if you're a young lad about town. But at the same time, things weren't quite the same for my women friends in Cambridge, because if they got into any sort of trouble, the particular college where I did most of my socializing, the women there had for them chosen a viciously unsympathetic religionist GP, and let's not beat about the bushes, Roman Catholic GP. And when faced with women wanting contraception or requesting termination of pregnancy, instead of saying, "Look, I'm terribly sorry, I can't see you, I'll send you to my colleague," he gave them a moralistic diatribe of a lecture. And if you're 17, 18, 19 and you get that from a doctor, it can absolutely destroy you. Now, if you're secure in your sexuality in your mid-20s or later, it's bloody annoying. You resist the temptation to bop him on the nose and you just wasted the morning. But for younger women, it's absolutely devastating. And as a partner of women in that situation, I felt as if it was almost as if they'd been mentally raped. It was a terrible scenario. And anyway, cut a long story short, I thought I can do this better. You don't have to be a genius to work out how to look after people as if they were your friends. How would you want yourself, your friends, your brother, your sister, your parents even, to be cared for? So that's how I got into sexual health, and it was something that motivated me right from the start of being a medical student. And it was this injustice actually that was done to the women that I saw around me. I suppose at the same time there was also like a double standard morality of, it was okay for men to mess about, but it wasn't for women. So it was part of the patriarchal society And I suppose I tried to do my best to kick against it, I guess. That's how it started anyway. And basically I just pursued that all the way through, and I saw this huge gap between conventional gynecology, mainstream gynecology, and sexually transmitted infections, which were mostly looked after by mostly sympathetic physicians who had no gynecology training. So I thought there's a big gap there, and I'll try and fill it. And to cut a long story short, I eventually opened the first integrated sexual health service where you could go for contraception and sexually transmitted infections under one roof without having to schlep from one place to the next to the next to the next to get seen. Anyway, that's how I got into women's sexual health. I've dedicated my entire professional career to trying to make consultations about sex and sexual health are just that little bit more civilized, and also that little bit more safe for people to feel as if they're being looked after by somebody who cares, I suppose, and also who knows what they're talking about, or tries to know what they're talking about, which brings us to where we are now, I guess.
Absolutely.
Sorry, that was rather long, but I don't know how long have you got? Well, actually, you've got to the point at which my PowerPoint presentation arrived with you, which is very clever. So there we go.
So we have had a bit of a technical hitch. So I'll be sharing Peter's presentation. Should we dive into your presentation now, Peter, before we go into the questions? How do you feel?
I think that's not a bad idea, because the thing is, there's bits of it. Basically, you're coming in and out of it, and whenever you get to a big picture with a question on it, that's the point at which you come out of it and we just start chatting. So you hit the first question, and then I'll go. If you just start and we'll talk around it, and then you can introduce it.
Well, I'm going to bring up your PowerPoint, and actually, as we're talking about localized provoked vestibulodynia, let's just start by some definitions here. What do we mean by vestibulodynia, and the differences between unprovoked and provoked?
Okay, fine. Well, it's in the name, actually. It's localized, so it's only in one very, very small place. It's not over the whole vulva, so it's not Vulvodynia. The din means pain, but the vestibule is the opening. Actually, I've got a graphic that's a little bit later on, but basically we're just talking about 2 small points, or maybe sometimes 4 small points at the entrance to the vagina. So it's actually a vulval problem, and it actually mostly involves discomfort, touch discomfort over the vestibular ducts, the Bartholin's ducts. The pain is not there, discomfort is not there if you're not touched. So if you're sitting around doing nothing, it doesn't hurt at all. So you don't have this continuous burning pain that a lot of women describe with the so-called burning vulva syndrome. It's not that at all. It's a completely different condition with very different treatments, which none of which also are as evidence-based as we like them to be. But it has a totally different approach to unprovoked, generalized vulvodynia. So this is vestibulodynia. It's point touch tenderness, and it's most obvious when you're inserting a tampon, or if you try to have penetrative sex or put a finger inside the vagina. That's the point at which it becomes tender, and you can actually localize it to within just a couple of square millimeters either side of the introitus. So it is. Actually, the areas involved are tiny, but they are enormously painful. That's probably the best way I can describe it. I hope that's good enough.
Yeah, and of course, as we go along, please pop questions in the comments box. If you need some clarification, just absolutely ask. So should we go into this PowerPoint that you've got here?
Because the thing that I sort of interests me most is because I'm interested not just in sexually transmitted infections and pain with intercourse and whatever. I'm also interested in hormones and contraception, and so I'm most intrigued by the fact that hormones are definitely involved in the genesis of LPV, localized provoked vestibulodynia, and there's quite a lot of evidence for this. Some of it's very good evidence and some of it's rather weak evidence, but there's definitely evidence of it. So I thought I would go through some of that for those of you who are interested. I think we can hit the next slide. So the question is, are hormones involved? And there are lots of different bits of evidence. The ones with the questions are anecdotal, but all the rest has very strong evidence base to it. So we know that it actually depends on which type of combined pill that you're taking, and it's more risky with certain types of pill with different progestogens in them. Remember, the combined pill has two components: an artificial estrogen and an artificial progesterone, and it's the progesterone type that seems to make a difference there. Also, we'll show you later on, it's more likely to happen the less estrogen you've got in your pill. Then there's a lot of anecdotal evidence, and certainly the French Society of Gynaecology is quite convinced that switching to Depo-Provera is one of the things that can bring it on. Depo-Provera is the injection that you have every 3 months, and that often causes vaginal dryness and difficulty with lubrication, and it can sometimes trigger, we think it can sometimes trigger LPV. It's also the same sort of thing happens when you move from a combined pill with estrogen in it to a progesterone-only pill, for very much the same reason probably as the Depo. And then we go a bit further down to the genetic links and the estrogen and progesterone receptor differences between normal women and women who are not affected by LPV and those who are. So if you just hit the next slide, this is the hardest bit, or the best bit of evidence that we've got, is a study from Canada. Oh yes, so the idea is that if we've got all these different things linking it to estrogen, linking it to hormones, there must be some sort of biological plausibility to the treatment. So it's giving a hint that estrogen is something to do with it. So if we just move on to the next slide. Now, it's very interesting that this is Céline Bouchard's study. She's in Quebec, and she looked at a couple of hundred women and found that if you compare to women who had never used a pill, who have a baseline risk of LPV, women who are on the highest risk pill, which contains levonorgestrel, known as microgynon, Ovranet, Maxeni, Rigivinon, lots of different names for it, that has 19 times more women were likely to have used that pill than those who'd never used a pill. And there was also a lower risk if you'd used pills with norgestimate in, which are called Celeste, Lucina, and Selique. So there's immediately some sort of link to the type of pill that a woman is using, and that got my interest. It is the only decent sort of population study that we have. It was done quite some time ago, nearly 19 years ago. So there's it'd be nice to have that evidence again for a larger group. So let's just move on to the next thing about what we mean by the different pills that people are taking. This is some work I did, a good 5 years ago now, 6 years ago, for Woman's Hour, where we looked at different women getting different degrees of mood with the different pills. And we go to the next one, which is an amplification of that slide. So you can see that for those of you who know something about pills and have been on the pill, you can see a lot of trade names on the right of the screen: microgynon, Ovranet, Levest, Rigivinon, Maxeni. Some of these you will recognize. The cheapest and most commonly prescribed pills are the ones at the top with levonorgestrel in them. They are more androgenic, in other words, closer to testosterone, and they're more likely to cause mood side effects. About a third of women put onto those pills will get very severe mood side effects, and hardly a day goes by that in my medical practice, or when I was practicing, that I wouldn't switch somebody from a microgynon pill or levonorgestrel pill to ones down the bottom of the list, to the norgestimate, Celeste, Lucina, Selique pills. But the really important thing is the ones at the top of the list are more likely to be associated with localized provoked Vestibulodynia than the ones at the bottom. But still, you can still get LPV if you're on the ones some of the ones at the bottom. So that's an interesting point. Let's move on to the next slide. So this is this business of a lower dose of estrogen. Obviously, Depo and progesterone-only pill have no estrogen in them at all. But if we go to the next slide, some work that was done in Israel, and this is the Greenstein's group from Tel Aviv. And what they found was that if you take a whole bunch of Israeli women, roughly 50-50 of them use higher dose pills and lower dose pills. But if you look at the bunch of women who've actually got LPV, many more women with LPV use a low-dose estrogen pill than those who use higher-dose pills. And if we just hit the next two buttons, so they took 132 women with secondary LPV. Secondary LPV, remember, primary LPV is a vestibulodynia that happens from first intercourse or from first vulval touch. And secondary is where you've had a history of being able to have some sort of penetration penetration, or to use a tampon, or to touch the outside, and then it starts to come on. Anyway, cut a long story short, 2/3 of these women are on the pill. But of the women who are on the pill, with a baseline of 50-50 between them, women who had the lower dose pill, it was 4/5 of the group were on the lower dose pill compared to the higher dose pill. So there must be something there to do with the lower amount of estrogen on board. Okay, let's move on. We're getting, it gets far. I decided I wouldn't put up the data slides here because it's far too complex. It's difficult enough for me to understand it. The genetic link to this is Anthony Goldstein's group from New York. I think he is from New York, looking at so-called contraceptively induced provoked vestibulodynia. And there was women who'd been on a pill, and in fact the only pill they were using there was Yasmin or Yaz, and with drospirenone in it. And they found that there was a link to the androgen receptor on the X chromosome, and that there were different. There was a different genetic makeup in women who had got contraceptive-induced provoked vestibulodynia compared to those who hadn't, and also they seemed to have lower amounts of testosterone in the tissues of the vulva. So there's obviously a hormonal link there somewhere, though quite what we make of this is difficult to be sure. But they think that testosterone's involved, and that the androgen receptors are important. And then in some other work from Leclerc in also in the States, there's, if you actually take samples from women who've got LPV, you find that they have different amounts, or smaller amounts, lower amounts of estrogen and progesterone receptors in the skin. So that's about as far as we go with that. Actually, we can cut the slides off now and come back to sort of normal conversation, perhaps. And in fact, I don't know whether you have any questions on what we just talked about, but the upshot of it is that there's definitely a hormonal element to LPV that probably relates to low estrogen, and also that it's genetically predetermined. So there are some women who, no matter what happens, they're not going to get this, and other women who are perhaps genetically likely to get it. There are probably many other factors as well.
Sure. And I think actually, I'm just noticing that I can hear myself back at me. I'm hoping that the sound is okay for people.
Sounds
watching.
fine.
It's okay?
Yep.
Let me just see what's happening here. Okay, I don't know why that's happening. All right.
I'm all right. I can hear you fine without feedback.
You can hear me fine. I've got the feedback, so it's a little bit disconcerting. I'll just take that off my ear for one moment. Okay, someone has said it is a bit echoey. So let me just. Right, is that any better?
I find it okay from my point of view.
Right, is that better? A little bit better. Okay. All right. I'm just going on what I can see in the comments box. So, all right. So, look, we talk about individualized care here, and some of these studies were done quite a while ago. And we can't really extrapolate and generalize too much from these, can we, Peter?
Well, there's hormones definitely got something to do with it, and what I started to notice was that well, in fact, there was a particular case that came up that sort of was my sort of light bulb moment, and I'll tell you a little bit about it. It was a woman who was postmenopausal, and she'd been on HRT. And because of the HRT scare that happened 19 years ago, which we're going to talk about a little bit later on in the show, she started within about 4 or 5 weeks of stopping her HRT, she suddenly developed very severe pain with intercourse with her regular partner of 6 or 7 years or whatever it was. And so she came to see me in my sexual health clinic. And when I looked at the vulva, she had blatantly obvious LPV pattern of pain, and also erythema, redness over the Bartholin's duct. And I thought, well, this looks exactly like LPV that you see in premenopausal women and younger women. And so I thought, well, the treatment of lack of estrogen and lack of vaginal lubrication in postmenopausal women is intravaginal estrogen pessaries, or creams, but the pessaries are probably better because they're actually made of estradiol, which is the natural estrogen in your body. And so I simply gave her the standard treatment of estradiol pessaries, which in those days were trade name Vagifem. They were slightly stronger than the ones that we use nowadays, but still, I gave her the standard treatment, and within 4 weeks, she was better. So I thought, hang on a minute, if I can use this treatment in postmenopausal women and their vestibulodynia gets better, why can't we give it a try in younger women? And so that's what we started to do, and with varied success, but a significant number of women seem to get better. I've got some data on that if you are interested.
Yes. Let us know about the data, because that's lovely that you've had that experience and that aha moment, and it'll be nice to know what that current evidence looks like.
It wasn't from years of academic study, years and years in libraries and whatever. God knows, everybody who has a concern for women with LPV will have spent yonks trying to do their best about it in whatever way they happen to do it. And this is a complete accident, but it gave me a clue as to what I might be able to do. And it has had some success for some women, but it's not robust. I wish I could put my hand on my heart and say, yes, we've done a bloody great big randomized controlled trial and it works. And that's not true. But there are some very positive findings, and I think we should just go through the very small amount of evidence that actually exists for it. So if you want to just put up the slides, the next lot of slides, start with that question thing from where we had got to, the question slide, whether it's, is it coming up? I can't see it coming up.
One moment.
All right, okay. Here we go. So let's just move on. Oh yes, I was going to, that was what the next slide is, the one that describes the actual what we're looking at and what I saw. Now you can, as you can imagine, I was not allowed to show the clinical pictures because this is Facebook and YouTube and whatever. Obviously, when I'm doing this medically in a lecture, there's lots of clinical pictures. But basically, the areas that are most commonly affected are the 5 and 7 o'clock positions, and you take a swab and you touch above and below and then on the spot. And the most amazing thing about it is that when you do this test, you only have to move the swab just a couple of millimeters away from the painful area, and it doesn't hurt at all. Now, there are some women who get pain right across the fourchette. That's from all the way from the 5 to the 7 o'clock position. Some women who get tearing down the 6 o'clock position, which is a slightly different presentation with different treatments. And also some women with the most severe LPV also get a hot spot, if you like, at the 11 and 1 o'clock positions as well. But the classic one is this 5 and 7 o'clock position. And this is exactly what I saw in this postmenopausal woman who'd been taken off HRT, and once again, she was better within 4 weeks of giving estrogen. So let's look at some evidence of treatment trials. Both of these are just these are. So here's the logic for this: is that we think that low estrogen causes localized provoked vestibulodynia in some women, and we know from actual evidence that it's a reaction to more androgenic contraception, and it's been proven that there's a genetic component to it. So the logic here is to try and change the contraceptive method that you use, if possible, to a slightly less androgenic method, if you can, and also to try and use estrogen. So just press the button now. That's the logical thing that we should think to do. That seems to me, or at the time, it seemed to be a biologically plausible way of proceeding, rather than any of the other treatments that have been tried. So this is a trial from the States where they used a score of 10, where the woman would say the touch tests were done, and they gave a total score of 10 for the whole thing. And what they used was an estradiol cream, so that's estrogen cream, which was mixed with testosterone. And in the actual paper itself, and the references there at the bottom for anyone who wants to look it up, that will have the precise details of what this cream was. Apparently, it was compounded in their local pharmacy. And the background to the women who were in the trial, 11 of there are only 50 women in the trial, and 11 of them were on the Yaz or Yasmin brand, and 6 of them were on a low estrogen brand and other brands like that. But basically, let's just hit the next button. You looked at a before and after, and so the average pain score before treatment was 7.5, with a range there from 9 to 9, probably to 6 or so, and post treatment the scores went down on average to a score of 2. Now, that obviously means that quite a lot of them scored nothing, but there will still have been some who are scoring maybe at 5 or 6 or so, but a very substantial improvement in that group. Now, the background to this is that this is not a randomized trial. This is a selected group of patients. There was no dummy treatment involved here. So but basically, we're sitting back and waiting for our friends in the States to do a randomized trial, and as far as I'm aware, they haven't done it yet. So that's
there was, I don't know whether you know, Peter, there was a recent review in Nature by Bergeron and Rosen.
Bergeron has done a lot of work on this. Go on. So
yeah, and look, we can kind of dive really deep into it, which we won't today, but the upshot of it was there. Let me just read this out. Hormonal therapies are not recommended for Vulvodynia treatment, although future studies might reveal a subgroup of patients who improve using cessation of hormonal contraceptive use in combination with topical hormonal treatment. So they were talking about the 2 small RCTs in women with secondary Vulvodynia from years back.
Right. Well, it rather does depend on which estrogen preparation you use and what sort of dose and how long you used it for. But also, once again, it's only going to be valid if one can actually do a proper randomized trial.
Right. Yeah.
So the only evidence that I've got at the moment is non-randomized trials. The fact is, if you think about it, if you're individualizing the treatment, you could almost say that if it works for the woman in front of you, then for goodness sake, it's not going to do her any harm. Estrogen and testosterone cream, or estrogen pessary, as I was using, there's no side effects from these other than a small number of women who get slight vulval irritation from the tiny number of women who get slight vulval irritation. And certainly for postmenopausal women, the particular preparation that I use is safe to use for life. So basically, no harm is done. Can you just move on to the next one, which is my particular group of women? And so this is a group of women, basically consecutive group of women, 29 women, with a minimum of 3 months of localized provoked vestibular symptoms. One of the women had a history of 15 years of trouble-free intercourse with her partner, and then followed by 16 years of severe vulval pain, having been switched to Depo-Provera. And when we tried her on the Vagifem, the vaginal estrogen pessary, she was better within 6 weeks. And able to have full penetrative sex without pain within 6 weeks. Now that's an anecdote, but if we look at the full, just to explain that the score was actually out of 20. So what I found, I don't know whether your viewers will find this as well, is that some women very few women have exactly the same amount of pain on both sides. Usually one side is slightly more painful than the other. So what I said was, when we done the touch test on both sides, I said, okay, which side is more painful? Okay, that scores 10. What does the other side score in comparison? And so some people would say, oh, it's 9 or 8 or 6 or something like that. And so the range of scores was actually from 20. So you add the two together, the range of scores was from 14 to 20. And so if we actually now hit if we think of what we actually did, we gave them lidocaine gel to start with, and many of them found that if the treatment worked, they could actually stop using the lidocaine gel. We gave them what we call basic psychosexual advice, which is PLIS, the so-called permission, limited information, and specific suggestions, without the IT, which is the intensive therapy. And basically, it talked about the usual sort of advice about trying anything and everything apart from penetrative sex, and drawing the man the diagram of what was going on, drawing a line above the Bartholin's duct and saying, right, okay, everything above this line is okay, if you see what I mean. And so, you simply do anything and everything that will involve clitoral stimulation, but without penetration. And then there's no other intervention. We simply gave them the pessaries. So if you just hit the button, and we'll see what this is the overview of the group. So the average score, the median score was 18, and after the treatment, and that was anywhere between 4 weeks to 10 weeks of follow-up. The post-treatment average was down to 4. With the range was actually much wider than that. The interquartile range was 0.5 to 8. So that's the majority of the cases. But if you look at the actual numbers, if you can hit the next slide, please. So we start with 29 patients scoring between, this is before treatment, scoring between 14 and 20. Hit the next one, please. So the next one is a group of women whose scores after treatment were 13 to 18. So really they had no benefit at all. Then we had another group who had scores of 5 to 10, so partial improvement. And then a larger group, the largest group, half of the patients had a good improvement. But even a partial improvement is better than nothing, and would allow some sort of activity, so noticeable improvement in activity. So what we've actually got is something that's highly statistically significant, but not randomized. And so what we're actually what we would like to do is to have pessaries that are placebos, and the company that makes Vagifem have absolutely refused to provide these pessaries. So there's no way that we can do the trial. So the bottom line here is that about half of the patients get better, and maybe just over 3/4 of them get some sort of benefit. What we don't know is what is it that defines why some of them get better and some of them don't. Does it have something to do with which pill they were on, or it's probably something genetic as well? Are there many other things? Could nutrition have something to do with it? Maybe it just is fluke. There's probably a certain amount of observational bias because it was only one doctor, myself, looking after the patient. But when a woman comes back to you after 6 months, a year, 15 years of pain and says, "I'm all right," then for the effect on the woman herself, and obviously as a clinician, you feel as if you've done some good. The problem is we can't prove it. That's the difficulty. However, if you go to the next slide, just go to the next slide. So the pathway that I would recommend, just my humble recommendation, is that you start by excluding vulvodynia. In other words, excluding the unprovoked vulvodynia, the so-called burning vulva syndrome. Exclude dermatological problems such as lichen sclerosis and other dermatoses. Exclude thrush and candidiasis and trichomonas, and use topical lidocaine and do this sexual health advice, limited advice. Change the contraceptive hormones if you can to a less androgenic progestogen, and give local estrogen, because finally the bottom line is it will do no harm. And it might do some good. So I think we've got just one more thing to hit. The problem is we don't know which hormones are the best ones and whether it makes an awful lot of difference. But we do know that this particular treatment will not do harm. And so it's worth trying.
So we talk about first do no harm, and we've got a couple of people who have commented that actually they get an allergic response to some types of vaginal estrogen, so Weston and estriol for a couple of people. Is there a particular one that might not provoke a
The clue is in the name. Estriol is Ovestin. Now, remember, there is the estrogen molecule is the main one in the human is estradiol, so that has two bits to it. Estriol is E3, and it's about 500 times less effective in treatment than estradiol, and so the cream that you use is much stronger. So that the treatment that I would use wouldn't be estriol, it would be estradiol, which is Vagifem, and there are a number of other pessaries that are made identically but by different manufacturers. It's interesting that I had one patient who had some vulval irritation with Vagifem and said, can I use a different type of pessary? Because she'd also tried Ovestin cream, which is estriol, but had some problems with that as well. And I looked online in the pharmaceutical makeup of the new pessaries that are just, they're effectively Me Too preparations with exactly the same components in exactly the same, all the excipients in the tablets. So there isn't a very good solution for the very small number of women who get irritation with these preparations. That's unfortunate. I don't have a solution for that, I'm afraid.
Okay.
We can take the slides.
Take the slides off? Okay.
Yeah,
so bearing in mind, I'm just noting the time at the moment, Peter, and I know that you'd like to talk about HRT. We can. As I was going to say, we can even do it another time, but we maybe just go into it in a little bit of detail, Sure.
or indeed. One of the things you could do is actually cut things here, and we can take as many questions as you've got that specifically relate to LPV. It's up to you. I'm at your service. Well,
let's go a little bit into HRT, and then we'll see which direction the questions take us.
Okay, fine. All right. Well, I'll be short, very short and brief about HRT, and I can quite happily talk the Heinleins off a donkey about it if you've got the time. But anyway, go ahead, fire away.
Actually, before we go into that, there's a question here about estradiol. Are there any particular names of these creams for external use? So I suppose you're looking for brand names.
The brand name was Estriol. Sorry, it was Ovestin cream, which is Estriol. And there are several other brand names for the preparation similar to Vagifem. I'm sure there must be some other brand names for the creams. I can't off the top of my head remember them because I have not actually used them apart from estriol. Obviously in the UK we're only limited to what was in the pharmacy at the time in the hospital. Obviously I'm practicing privately. I could prescribe anything I wanted to, and I just have to go away and look it up. I'm sorry, I haven't got those names off the top of my head.
I'd recommend people go in and talk to their pharmacist on this one. What's an alternative to Vagifem with the same ingredients? That's what I'd say. So yes, please talk a little bit more about the HRT. I think that's
okay. Well, we were going to start talking about the myths about it and the safety concerns. So I think just put a couple of slides up. I just show some of the. So obviously for people who aren't quite so long in the tooth as myself, they may have, so let's move. Sorry, I think there's a question mark slide, and then we just show a few. Oh yes, okay, right. Myths versus reality. Now the biggest tragedy was this study called the Women's Health Initiative in the States, which was published in 2002. Actually, it wasn't published first. It actually appeared first in the New York Times before many of the principal investigators had a chance to actually look at what there was being said. And basically, this study was designed to see if the benefits that had already been shown to work for younger women who are just immediately menopausal in their early 50s, to see if those benefits could be offered to women who are much older. So most of the women in the study, this American study, were actually, the average age was 63, and there was even a woman at age 79. Now, nobody in their right mind would suddenly start HRT in a 79-year-old. So they used the wrong women. They were too old. They were because they're Americans. There was a very sizable amount of obesity. So in shorthand, they were too fat. They were also too ill in the sense that quite a lot of them already had cardiovascular disease. Also, wrong drug. There's no way, nobody in Europe would have used the conjugated equine estrogen, the pregnant mare's urine. Nobody uses that nowadays, and also nobody uses medroxyprogesterone acetate. So the progestogen, it was the wrong drugs. Also, almost nobody who's a menopause specialist nowadays actually uses an oral preparation, because that increases your risk of thromboembolism, so of clots. So wrong drug, and then the wrong headlines. But it was enough. So let's just give you a couple more headlines. So there was apparently an increased heart attack risk, and then again, next slide, an increased breast cancer risk, and all of these things put together were quite enough to cause, obviously, absolute mayhem in the profession, and also, of course, for women themselves. And as the let's leave it on that thing at the moment. No, back to it's fine. As the studies were reassessed gradually over the years, all of the original assumptions of these studies, or all the original headlines, have now been debunked. So finally, the NICE guidance comes out in 2015 saying that HRT is not a danger to women, and because of partially because of demand, and also because of something that happened in relation to Brexit and the NHS pricing system, more and more women got onto HRT transdermally, which is the correct way to take it rather than orally. The most effective way to take it is transdermally. It has much better effects on mood and sleep and whatever. And so there was the patches started to run out. And that brings us up next slide to where we are now, is that, next one, sorry, is that you really need to have seen this Channel 4 program to have a real understanding of what's going on with the lack of good quality management of menopause, and a lack of understanding of menopause and menopause issues and perimenopause issues amongst your average GP. Now, there are many GPs who are actually very well trained in this, but the vast majority aren't. And the reason is that they've actually been given the wrong information to tell patients over the last nearly 20 years. And it's only relatively recently that the penny is actually dropping, that most of what was originally told about HRT is actually wrong. So actually, I'll tell you what, we can probably go to the next slide, if I can remember. Oh no, go on one more slide, and then we'll look at, oh yes, sorry,
double question mark.
Oh yes, I think one of the slides has got missing. We were going to talk about, oh yes, actually let's go back to the question mark for the moment and just think about this. So we're in a situation where everything that not only you, i.e. the general public, but also your GP have been told for the last almost 20 years is actually wrong. In other words, doctors were telling you there's a risk of heart attack, there's a risk of breast cancer, so don't take it unless you really have to. You take the lowest dose for the shortest time, don't take it after the age of 60. All of these things are individually and collectively wrong. And that's a bit of a problem. Mm-hmm. So I thought we would press on from there and look at what the benefits, the known benefits of HRT actually are. Now, this is actually, this was known before 2002, before the Women's Health Initiative scandal and the Million Women Study scandal. So the bottom, actually, I've deliberately started at the bottom here. The bottom line is that if you take women between the ages of 45 and 60 and give them HRT for 10 years, you can have a lower all-cause mortality. In fact, you have a one-third reduction in mortality. Now, I think anybody in their right mind would want that, but there are actually, it'd be jolly nice not to die. In fact, that's largely due to protection against heart attack, which once again is the opposite to that which you've been taught. So let's go have another hit. Now, if you think about it, we could spend a long time talking about the various different symptoms of perimenopause and menopause, because basically what you're dealing with is an estrogen deficiency syndrome. And to give this a little bit more political clout, if you just imagine a situation, if you took a 52-year-old gentleman who has suddenly sort of wanted to get himself completely liberated, he's having his midlife crisis, and he buys his Harley Davidson. And he's got no excuse. He's got no real experience of motorbike. He comes off, has an accident, comes over the handlebars, and takes his balls off in the process. There isn't a doctor in the world who wouldn't give him testosterone replacement therapy. So I'm sorry, that's a rather very male-orientated way of looking at it. But if you have estrogen deficiency syndrome, i.e. menopause, be it surgical, premature ovarian insufficiency, or natural menopause, why on earth would you not want to take an estrogen supplementation? Because estrogen is involved in all tissues of the body, and the use of estrogen, its benefits massively outweigh any theoretical risks. And that's been known for many, many years. And once again, it's only misinformation that's crept in since then. So better quality of life. I mean, if you think of the major things, insomnia, and brain fog, probably, and obviously the mood that is associated, the lower mood that's associated with not being able to remember what you were going to say. Obviously, your hot flushes and night sweats are troublesome as well. But realistically, and also the joint pains are not normally mentioned, but that's a very major part of it. There's a whole load of symptoms one could list. Let's move on and look at some of the other benefits of you. So you're more likely to improve cognition. That's the reversal of the brain fog that you get with menopause. Your estrogen, we go to the next point of osteoporosis. Estrogen is the first line treatment for osteoporosis. And in fact, because of my generation, I'm of the age of the women who would have been about 51, 52 when the scandal actually hit. And that generation of women have missed out on being treated with estrogen. So they'll have a much higher risk of osteoporosis. Now, the next bit, preventing heart disease, is actually very important because estrogen protects your heart, and it's better for conduction in the heart muscle. And I've got a couple of slides on that in a moment. And another thing that's been known for many, many years is that you reduce bowel cancer risk by about 10% or so. So the final thing that we need in this benefits of HRT known before 2002, if you just like to hit the button again, is something that not everybody knows, is this longer survival after breast cancer. Now, that was known 20 years ago. And I think we need to tease out some of these things, the heart disease and the breast cancer just now. So let's just very quickly do heart disease and breast cancer. Next slide, and we'll see what we come to. So, so what the headline should have said was millions are in danger of not taking HRT.
Right.
And then the next headline should actually be, wait a minute. Yes. So go back. Can you go back actually? So go back one slide. That slide. So here are the risks of not taking HRT, which in fact is the opposite to what I was showing in the previous slide. The bottom line is you're more likely to die. How about that? Also, you have a poorer quality of life with all your insomnia, your brain fog and everything else, which we talk about with impaired cognition. You're much more likely to have osteoporosis. You're more likely to get a heart attack or have heart disease. You've got an increased risk of bowel cancer, and you're more likely to die if you're unfortunate enough to get breast cancer. So that's what happens if you don't take HRT. Now, that's a little bit different to the message. That's
just a little.
Just a teensy bit. Let's get deadly serious about this. In the first 10 years, in the States, it was calculated that after the first 10 years of HRT, of not having HRT, there were probably some 50,000 excess deaths from heart attack in women. Aged between 50 and 60, and also in the same age group, an excess of similar number, 50,000 extra spine and hip fractures that wouldn't have occurred if they had actually had their HRT. So that just gives you some idea of what's going on. Let's move on to the next bit. We're going to do heart disease just now. So yes, HRT is related to heart attack. You're less likely to get a heart attack if you're on HRT. So let's just show the next slide, which animates by itself. Now, this is a sort of schematic thing, is that men have a much higher risk of heart attack at all stages of life than women. But if you now press a button again, we look at women who don't take HRT, their risk is lower until the point of menopause, and then it goes up at the same rate as men. It never approaches the same amount as men, but it goes up at the same rate. But if you take HRT from the time of menopause, then your risk of heart disease is very much reduced, because it actually reduces atherosclerosis, prevents your blocked arteries. It's much better for nerve conduction and improving sugars and fats. So final thing is a bit of actual hard evidence. Next slide. Real hard evidence. I think death is a pretty robust endpoint. Actually, for any of you scientists here, that is a pretty good death or admission to hospital due to heart failure or heart attack. So they took women actually on oral HRT. This is a Danish study, and you can see the point at which the trial was stopped because of the Women's Health Initiative data. They stopped the trial at this point, and the women who were on HRT had a significantly lower risk of death and all the other things than people on placebos. Then they stopped the trial, hit the button again, and after a little bit of time, the rate of decline suddenly accelerated in the women who had been on HRT. And so the upshot of this is, the advice on this is, your heart attack rate increases when you stop HRT. So why on earth would you want to stop it? Also when your brain fog comes back and all the other things, and your hot flushes might or might not come back depending on how many years later. So this is a very good reason to take HRT and to continue taking it. And there's no doubt about that at all. Let's move on to the thing I think that most women are concerned about is this link to breast cancer. And what not a lot of people know, as Dr. Michael Caine would say, is that HRT is linked to less chance of dying from breast cancer, which has really got to be the bottom line. So let's just show the next slide. These are some of the headlines, and the Million Women Study Group came back again with another, in some ways, false alert in relation to breast cancer. And I think I can say that reasonably because of the way the work was done, that they were looking at older data and also the types of HRT that are no longer used or very rarely used in this country now. So this particular slide. This was known. This was from Denmark. It was known in 1999. So that if you look at the green at the top, if you happen to be unlucky enough to get breast cancer, but you're on HRT at the time, after 10 years, 4/5 of women are still alive. But if you've never had HRT, only 2/3 are still alive at 10 years. Now, once again, as Dr. Michael Caine would say, not a lot of people know that. And it's absolutely the opposite of what you have been taught, or what your GPs have been taught, or what you might surmise. Let's go to the final sort of bottom line here is death in the whole population of Finland, looked at over a very large study. This is published in 2016. And the bottom line here is that if you get breast cancer and you are on and you're not on HRT, you have a 1 in 10 risk of death, and if you're on HRT, you have a 1 in 20 risk of death. And if you now press one more time, just to summarize the wodge of data is there, that for the younger women, they are 2/3 better off, 2/3 less likely to die in the 50 to 59-year-old age group, through 1/3 to 1/4 for the older age group. So at all ages of diagnosis, women are better off more likely to survive breast cancer if they're on HRT than if they are not. So next slide. Is this everything that, this is what the headline should show. I'm deliberately putting this slide up because it took me about an hour or so to graphically redesign the slide to say what it should have said. I sweated blood over that slide. And then finally, next slide, and this is the last one. So is is it a small effect, or is it in fact, as our dear departed friend says, fake news? So there we go. I think I think we're just about finished now. Oh yes, there might be a conclusion slide. Next one, please. See if. So the guidance from NICE and also the British Menopause Society, which has actually given this advice throughout the last 20 years, is you individualize the treatment, use whatever dose works. There's a minimal risk of breast cancer and better survival after breast cancer. It's the best thing you can take for bone protection. It's certainly best for all sorts of wider quality of life issues, such as better skin, better hair, better cognition, and it prevents heart attacks, so that's pretty good. And the question then, when do you stop? Well, don't stop. Why should you want to stop? I mean, you can always tell a 70-year-old woman who's on HRT because she looks and acts 60. And I don't understand why one would want to stop, because there's no good medical reason to stop unless you actually have an estrogen-sensitive cancer. That's the only reason I can think to stop. Once again, we're talking about transdermal preparations rather than oral preparations. So I think we're just about done. I can't remember whether I put any more slides in at the point. Oh yes, the old advice is the lowest dose for the shortest time, and the new advice is as much as you need for as long as you live. That's a pretty good punchline on which to finish. I think we can wipe the slides out.
As much as you need for as long as you live.
Absolutely. But,
Brilliant.
with the doses individualized, of course.
Of course.
And you know, the proviso that, of course, the really difficult thing about managing HRT is managing the progesterone, which is there to protect the womb lining. So it's much easier, of course, if you don't actually have womb, if you had a hysterectomy, but that we can, you know, that's another lecture some other time. But that's the short advice. You know, as much as you need to suppress whatever, to improve yourself back to your premenopausal or your perimenopausal state. So I hope that's a positive view of it. Maybe it's too positive, but I'm a positive sort of person.
Peter, brilliant presentation, brilliant messages. We've got a whole load of questions, and I'm mindful we've only got a few minutes left, but what I'm going to say is we're probably going to go a little bit over. Okay, if people are okay with that. Let's go a little bit over, if that's okay, Peter.
I'll be as quick as I can with the questions then.
Okay. So there's a few questions here, but before we get on to those, when's the best time to start HRT?
As soon as you need it. In fact, many women get these type of symptoms cyclically well before they actually have their last period. That's called the perimenopause. And you start HRT during the perimenopause so that women can surf seamlessly through. So you can actually suppress the symptoms. If you can suppress the cycle properly with a hormone coil, one of the best ways of doing it. So starting HRT when you start to get estrogen fluctuation and fall symptoms, which are there's a huge list of symptoms once again, which is there for effectively a different lecture, I'm afraid.
Is there a good enough blood test to show?
No. You don't need any blood tests at all unless you happen to have stopped having periods under the age of 45. So that's or your periods are very erratic under the age of 45. That's a point at which it's worth doing a blood test. But over the age of 45, there's no point doing an FSH test or indeed estrogen tests or any of those tests, because what matters is not the level of hormone, because the level fluctuates anyway, but it's the individual woman's response to the hormone or its hormone lack or falling level, which is genetically predetermined. So different women react differently. There is about 10 or 15% of women have no symptoms whatsoever, and then suddenly, no problems, suddenly stop having periods, don't have hot flushes afterwards. Lucky bees, basically. Very few are in that situation, but they wonder, what's it all about? You know, why are people making such a fuss? However, on the other extreme, there are about 40% of women who are virtually non-functioning without estrogen, and then a group of women in between who have more subtle effects of lack of estrogen, and in whom it's more difficult to demonstrate that there's a benefit, but there is actually a benefit. So it is very individualized.
Is there such a thing as being too old to start taking HRT?
Interestingly, no, provided you don't take it orally, and provided you don't take it at maximum dose. Normally, certainly if you're into your mid-60s and you've missed out on taking HRT, and you still feel as if you could benefit, we know women will benefit at least for bone protection. And in fact, even if you use about a quarter of a standard 50 patch, that will actually give you protection against osteoporosis just on that minuscule dose. So even if you don't, you know, if you haven't got the hot flushes, even if you haven't got the brain fog or all the other, you know, the cognition difficulties or whatever, it will improve your skeleton. It will also probably improve your skin. It will probably improve the joint pains that many women get, because it has a direct effect on cartilage and connective tissue. So it's beneficial almost at any time. However, trying to convince an ordinarily trained GP of that is actually quite difficult, I'm afraid.
So any tips for that? We've got someone who came off HRT nearly 2 years ago, went on to develop a tight pelvic floor. She's 59 years old, wondering whether she dares to ask the GP to give me the patches again.
Well, if she had a tight pelvic floor, then hopefully she would have had some pelvic floor physio to start giving us some advice on this. And there's a great collaboration between physiotherapy and HRT, because certainly women who are perimenopausal will get cyclical joint pains, and you can actually, they go to their physiotherapist a lot more, and you can actually treat them with estrogen, and it improves the situation. For this, in this woman's situation, it depends on what other symptoms she has. Also, as to whether the tight pelvic floor means that she's got a vulval pain syndrome. Now, remember, managing the vulval pain syndrome, total vulval pain syndrome without specifically vestibulodynia, is a it's a multidisciplinary task.
Absolutely.
Although hormones may be helpful in this scenario, lubricants may be helpful, pelvic floor physiotherapy also very helpful indeed. And a tight pelvic may mean that she's actually got some muscles that have actually gone into spasm, and the best way to deal with that is pelvic floor physio and intravaginal massage, which very specifically trained physiotherapists are very good at doing. So I would, in a situation like that, I wouldn't blame the tight pelvic floor on the lack of hormones. I would say what other things are going on in her life. In other words, how good is her memory? How good is her sleep quality? Remember, it's not just the night sweats sleep, but estrogen has the direct effect on sleep. And if you have lack of estrogen, then you don't get as much non-REM sleep, which is the deep restorative sleep that women need. And even if you do sleep the whole night, a lot of them will wake up completely unrefreshed. And then that adds into the brain fog problem, because they're unable to concentrate because you wake up totally knackered in the morning. So it's a global thing, and you can't just point at one symptom or the other and say, oh, yes, estrogen will help with that symptom. It actually helps with a huge range of things, some of which are much more subtle and not as well recognized as others.
Okay, so again, Peter, there is no doubt we're going to have to get you back at some point. Another quick question. Thoughts on topical estrogen combined with topical testosterone for premenopausal vestibulodynia?
Now that's interesting, because that's what the American group were doing. And that, as far as I can see, is the only evidence that they produced. So if we think that there's an androgen receptor is involved, if we think that lower testosterone levels in the tissues around the vulva are involved, then it seems to be logical to add testosterone. And once again, from that uncontrolled trial, they had a significant benefit. So I think that the right thing to do is, in fact, if people can, I don't know whether this is recorded, so people can actually go back to the reference. And if people actually want the references, I can give you the references anyway. And if they want to look it up and then contact, I either get their doctor to contact that team and see what was used. But I have no experience of using testosterone, because I use testosterone for libido, for mental sharpness, interestingly, and for stamina, which it also improves it. So it's not just for libido. But whether testosterone cream in the vagina would work, I wait to be convinced, but then I haven't done the work. But I'd like to see, just as somebody might ask me and say, okay, you're giving Vagifem, where's your RCT evidence? I'd like to say this, I'd like to see more evidence from our friends in the States.
Yeah. Yes, fingers crossed, and more than that evidence can be produced. We definitely need more evidence on that, don't we? There's one here. Let me just pull this up. What about estrogen dominant symptoms due to not taking progesterone after a hysterectomy? Do you not require progesterone for balance of hormones?
Oh, there's only a tiny number of women who require progesterone after hysterectomy, and those are women with severe endometriosis who haven't had all the bits of endometrium, ectopic endometrium removed. So the only role for progesterone for most women post-hysterectomy in menopause it hasn't got a role. You don't need it. And in fact, it's interesting, a lot of women are progesterone hypersensitive, and certainly women with PMS, PMDD are progesterone hypersensitive. And although in the UK and in most jurisdictions, most gynecological setups or organizations, you would say that you do need to take a progesterone of some sort to protect the womb line if you've got a womb to protect. In France and in Finland, I know for a fact, because there are large numbers of community gynecologists, women do not take they take unopposed estrogen. They don't take progesterones. They go to their gynecologist every year for a scan and a Pell sample to check that they haven't got endometrial cancer. And remember, we would never be able to do that in the NHS, and it just doesn't seem appropriate, because you have a 1%. If you have unopposed estrogen, in other words, estrogen without progesterone, and you've got a womb that needs protecting, you have a 1% annual risk of endometrial or womb lining cancer. So that seems like a good idea to take progesterone. However, once again, different medical systems do it differently.
Mm. Yeah. I wish we had more time. There are so many questions coming in. That was a brilliant presentation. Any final words, Peter?
I actually just wanted to say that the people may not appreciate quite how brilliant you are in structuring the questions and getting the technology right. So I'm enormously appreciative to you, Sheren, of getting it right. And,
it's been a pleasure.
Happy to come back again for. Actually, I'm sure that you could have, if you had the questions, and we had the questions in advance, we could actually do an entire talk based on your women, your subscribers' questions. Very happy to help with that.
We may well do that in future. Yeah, there's calls for you to come back. Any wrap-up points, Peter?
Well, I think what we have to say, as far as LPV is concerned, from my viewpoint, estrogen will be helpful, and it shouldn't hinder in any way and should not do any harm. However, the formal proof isn't there, and goodness knows I would like to find somebody who had a bit more OCD than myself, who was able to actually do the research and come up with the goods. But the problem is that so many of the well-established research groups don't seem to have done anything about estrogen, and I'm sure that it is important. So that's number one. On the HRT front, it is unfortunate that few GPs not enough GPs have had the training, but people are now getting a much better idea that menopause, affects 50% of the will affect 51% of the population, and more severe things that we didn't really talk about, such as suicidal ideation and the menopausal transition being the principal time for attempted suicide in women. So it's deadly serious stuff, and we've got to get it right for our women's lives, for family life, for the general place of women in society, to allow them, if you like, to help them to equal up, because of this imbalance. It's hormonal imbalance, it's societal imbalance, and I think if this was a problem for men, it would have been sorted long ago. Yes. And I think I would actually just give one last tip, is that if anybody hasn't seen the Vina McCall program, then they jolly well need to see it on playback, because it is critically important. Yes, a final other tip about the workplace. For women in the workplace, getting perimenopausal and menopausal symptoms sorted out and managed properly is very important, because obviously if you can't concentrate on your work, then some women have actually faced industrial tribunals and are inappropriately victimized at work. So you need a proper workplace policy, of which, interestingly, the best has been produced by the police. So look at the police menopausal transition workplace policy. It says it all, and other businesses would be well advised to take it on. But there's too many things to say. Final thing then is just thank you very much for having me, and I hope it hasn't been too boring.
Oh, it's been absolutely brilliant. We must have you back. I just want to say thank you to Steph, who has shared the Make Menopause Matter petition. Yes. She's popped it up in the comments. Look, please do sign the petition. We need to shout about this. Change needs to happen. And there is a resource where there's a list of menopause symptoms that people can look at. We'll pull that up and pop that in the comments as well. Mr. Peter Greenhouse.
Yeah, I've got some materials I can share if people want.
Yes, please. That'd be amazing. Yeah, okay. And we'll make that available. Thank you so much, Peter. Consultant in sexual health and menopause specialist. We will definitely be having you back.
Thank you.
Before I reveal what we'll be discussing next time. Just a reminder that all our live streams remain up on the Vulval Pain Society Facebook page and our YouTube channel, so you can watch and you can re-watch anytime. There's going to be a lot of re-watching of this one, I can tell you. On our YouTube channel, we also have a selection of our Ask the Expert webinars from 2020 and some presentations from previous years too. If you follow us on social media, on Facebook, YouTube, Twitter, you can be notified of upcoming events. So listen, you might just want to go ahead and follow us on any one of those places if you haven't already done so. And if you have already started following us, thank you. Our new website will be going live later, maybe late summer, early autumn. And there'll be a contact form for you to ask questions more easily. In the meantime, you can email
info@vulvalpainsociety.org.uk.
And our existing website also has a ton of resources.
vulvalpainsociety.org.uk.
Our next live stream is an interesting one. It's with Kath Reeve-Jones, senior midwife at Berkentine Birth Centre. Now, this centre, this integrated midwifery team, was launched by Jennifer Worth, who's the author of Call the Midwife. Kath will be talking about whether vaginal examinations in labour are necessary, and we'll be discussing the important matter of consent in labour. So that will be on Tuesday, the 6th of July at 7 p.m. BST with Kath Reeve-Jones, senior midwife. That's all from the Vulval Pain Society for now. Thank you again, Peter Greenhouse.
Bye.
Thank you, everyone, for joining us live or on the replay. Bye for now and see you next time. Cheerio.